Hello friends, this is Professor Dr. Sameen Afzal Junejo from Afzal Eye Clinic, Hyderabad, Sindh, Pakistan. Friends, yesterday a patient came to me and he was very much worried about his treatment of prostate using the tamsulosin orally since many years. He was very much worried and his query was that his pupil is small, cannot dilate, does not respond to the mediatics, and the Phaco is not possible. And many surgeons have regretted to go for the Phaco surgery in this case. Well, I arranged a separate session for him, and today I operated this case at my operation theatre at Afzal Eye Clinic, Hyderabad, Sindh, Pakistan. And I tried to dilate the pupil, but it could not dilate beyond 1 to 2 millimeters, and the pupil was almost 3 to 3.5 millimeters dilated when I started doing the capsulorhexis. And in spite of using the mediatics and also the phenylephrine 10% drops, the pupil was not responding to the medicines. I decided to do the Phaco in a small pupil, and as I always do the capsulorhexis with the cystotome needle, and my surgical is approach always through the surgical nimbus. And surgical nimbus, you know that it is slightly behind the anatomical nimbus or the gray line of the cornea, and the small pupil acts as a guard towards the rhexis being performed, and in this case I have completely done the round rhexis underneath the pupil, which is becoming a bit more smaller. So in this situation I will not use the hooks because the patient is 65 years plus age, and the iris sphincter might be weakened, or the sphincter might be degenerated or weakened, fibrosed, and when we apply hooks in such a condition, then they can damage the sphincter pupillary muscles completely and permanently, and postoperatively the pupil remains in a semi-dilated position, can give rise to many complications, hazards like photophobia, scattering of light, flashes of light, and something like that. So I usually prefer going for the Phaco in small pupil directly instead of manipulating the iris and applying the other measures, taking the help of the hooks and the rings. And now, as you see that in such a small pupil I am doing the capsulorhexis, and as you see that due to the immense release of prostaglandins E2 from the iris stroma, the pupil is becoming smaller and smaller further. As I proceed with the surgery, pupil is getting smaller, and now it is a tiny small pupil, not more than 3 to 3.5 millimeters, and in presence of OVD dispersive and adhesive, I have started just in the middle of the lens nucleus, and under a vacuum of 550 I am trying to pull the nucleus out of the bag, and I succeeded. Through a small pupil, nucleus has been pulled out of the bag very successfully, and through the equator of the nucleus I am trying to make a small fragments of the nucleus, keeping the phaco tip exactly in the middle of the pupil in order to avoid the iris catch. And once the iris or the pupil is bitten, then there can be a permanent deformity postoperatively. So I always try to keep the phaco tip exactly in the middle of the pupil at the supracapsular level, and now one by one I am just taking the small fragments at the tip and applying a linear phaco energy gush, a linear gush of phaco. I am trying to complete my phaco emulsification through the small pupil. My dear friends, as you have seen that the lost fragment is now being taken up under a high vacuum of 550, and almost the nucleus is completely being removed, and now the epinucleus and a bit of the thick cortical matter. Here we have done with the stage 2 of the phacoemulsification in extremely small pupil. You can see the adhesions, the brown pigmented adhesions at the side of the pupillary rim, and now I am injecting OVD dispersive. As you see that at the site of the phacoemulsification, where I have given the full thickness corneal incision, there is a fish mouthing. Instead of using a minimum phaco energy, patient has developed a fish mouthing at the corneal incision site. And now my ideal instrument, that is a two-way irrigation and aspiration cannula, is being used for the removal of the cortex. Pupil is still becoming more smaller due to the release of prostaglandins E2. A small piece of cortical matter is stuck up at 12 o'clock position, and I will remove it through one of the side ports with the help of a Simcoe cannula. One should be cautious about the movement of the Simcoe cannula while doing the irrigation and aspiration in presence of a small pupil. Should not take the risk of going deeper and deeper into the near the posterior capsule or inviting the posterior capsular rent. Viscoelastic solution is injected into the bag, and now a foldable intraocular lens is being implanted exactly in the bag. Now, if we think of such a small pupillary size, and when we think that and then we should ask the questions about the use of tamsulosin. Other causes of the small pupil are uncontrolled diabetes mellitus, recurrent uveitis, and iridocorneal adhesions. Can be developmental, can be acquired. In all these conditions, pupil never gives any response to the topical mydriatics. In this case, I have tried my level best not to injure or traumatize the pupillary margin during the whole procedure of phaco emulsification. Pupil is getting smaller, and I will definitely prescribe the postoperative frequent use of topical steroids to avoid postoperative cellular reaction or any form of postoperative transient inflammation. Such an inflammation, which is although mild and transient, but can give rise to endophthalmitis even due to the prostaglandin release. Now, a one-piece intraocular lens is being implanted exactly into the bag through the corneal incision. Now I have again felt necessary removing the viscoelastic solution in order to keep the media neat and clean postoperatively. My dear friends, as you can see in this case, that pupil has gone myosed. Although I have not yet used the cocktail injection of pilocarpine, antibiotic, moxifloxacin and the decadron. Anterior chamber is quite well formed. Cornea is by itself hydrated and the procedure is complete. Thank you very much. My dear fellows, if you like this video, please like my channel and subscribe it. Thank you very much.